This next lesson will cover the autoimmune condition rheumatoid arthritis, abbreviated RA. RA is another systemic autoimmune disease. RA primarily affects connective tissue, especially that found in the synovial joints, like those found in the joints of the hand. RA is the most common of the autoimmune diseases, as depicted in this image here. As a type of arthritis, RA is third most common after two other arthritis-causing conditions, osteoarthritis and gout. Unfortunately, RA is one of the more debilitating forms of arthritis compared to some others. It currently affects about 2.1 million people in the United States, which is a prevalence of about 1%. It is more common in women than in men in a 3-to-1 ratio, and it is slightly more common in Caucasians than individuals of African American descent or other ethnicities. Most new diagnoses occur between the ages of 40 and 60 years old, and in general, the incidence increases with age. There are several factors that contribute to the etiology of RA, including genetic, endogenous, and environmental factors. RA does run in families, with individuals having a six-fold higher risk of developing the disease if they have a first-degree relative with the disease as well. Other evidence to support genetic links include twin concordant studies, which show a 30-fold higher risk between identical twins. Several genes have been identified that contribute to the development of RA, and it is a multifactorial genetic condition. The primary genes identified include those that encode human leukocyte antigen, or HLA, which encode proteins found on the surface of T cells. Therefore, it's not surprising that the genetic changes would be to the immune function. In terms of endogenous factors, sex hormones have been thought to play a role given the increased prevalence in women, and the fact that RA symptoms are known to regress during pregnancy. This suggests that progesterone reduces the symptoms of RA, whereas estrogen promotes inflammation and damage. And finally, environmental factors are thought to trigger the initial onset of the disease. Exposure to some unidentified antigen in the environment, or perhaps recurrent Epstein-Barr virus infection, have been hypothesized to play a role. RA pathophysiology exhibits elements of both type 3 and type 4 hypersensitivity. In terms of type 3 hypersensitivity, we've already talked through the tenets of that model. If you're not sure, go back and watch the video about lupus before watching this section. In the case of RA, the type 3 hypersensitivity manifests itself as autoantibodies being synthesized against various proteins in the body. These autoantibodies are called rheumatoid factors, or RF. In the case of RA, the antigen is actually a piece of an antibody fragment. These antibody fragments that are circulating around the body generate an immune response that results in the production of rheumatoid factors. Antigen-antibody complexes then form and accumulate primarily in the joints, which is what leads to the clinical presentation of the disease. About 75% of patients with RA have some element of type 3 hypersensitivity, and this is known to predict a more aggressive course of the disease. In addition, many individuals with rheumatoid arthritis exhibit type 4 hypersensitivity. This is cell-mediated hypersensitivity, where activated Th1 T cells infiltrate the joints, release cytokines like TNF-alpha, interleukin-1, and interleukin-6 that trigger an inflammatory response and the recruitment of additional cells that cause damage to the joint area. We will more closely examine type 4 hypersensitivity in the video on psoriasis. So for now, just remember that RA includes elements of type 4 cell-mediated hypersensitivity, which involves Th1 T cells. The main identifying feature of RA is the fact that these hypersensitivity reactions cause significant inflammation in the joint space. And this inflammation eventually causes irreversible tissue injury. I'll say that again. The damage in rheumatoid arthritis is not reversible. Following the inflammatory response, white blood cells release damaging enzymes and reactive oxygen species in the joints. In addition, chemical mediators of inflammation increase blood flow and vascular permeability. There is also a process known as pannus formation, in which the joint reacts by becoming hyperplastic, which means turnover and synthesis is increased. This causes invasion of cartilage into spaces where it normally would not be found, as well as erosion of bone and cartilage in other areas of the joint. This can lead to decreased motion at the joint as well as bony fusion. Although the primary tissue injury in rheumatoid arthritis is to the joints, there are some extra-articular manifestations in some, but not all patients. This primarily includes vasculitis in various organ systems like the skin, heart, brain, lungs, and GI tract. The early clinical presentation of RA includes some initial joint stiffness and swelling. This joint stiffness is typically most prominent in the morning for the first 30 minutes upon awakening, and may persist all day. Over time, the smaller joints are affected first, and these are joints like the fingers, hands, and wrists. And this will progress to involve larger joints like the knees and ankles over time. Another primary feature of RA is the fact that joint involvement is symmetrical, meaning it is even on both sides of the body. And this is because the joint dysfunction is caused by an autoimmune condition that is happening throughout the body, and therefore joint involvement or dysfunction will be even across the midline of the body. Later in the disease process, there may be some joint deformities that are observed, such as ulnar deviation, swan neck deformity, as well as other signs that begin to occur over time, such as subcutaneous nodules, known as rheumatoid nodules, vasculitis, as I mentioned, as well as other signs of systemic inflammation like fever, fatigue, and weakness. Patient assessment for RA can be categorized as either immunologic or blood testing and clinical signs. In terms of blood testing, there are a few antibody tests that can be conducted, some of which I've mentioned already. The first is known as the anti-citrullinated protein antibody test, or the ACPA test. This is the most specific for RA, meaning that a positive ACPA test is usually diagnostic for RA. Unfortunately, only between 50 and 80% of patients exhibit ACPA antibodies. Another result that might be seen is positive rheumatoid factor test. And this is something that tests for the rheumatoid factors or antibodies present as part of a type 3 hypersensitivity reaction. This is somewhat specific for RA, and about 60 to 70% of patients will exhibit positive RF test. Anti-nuclear antibody test is another way to determine the presence of RA. The anti-nuclear antibody test, as I mentioned previously, is not specific for any given disease state, but just generally indicates the presence of an autoimmune condition. About 25% of patients with RA will exhibit a positive ANA test. You may also see elevated erythrocyte sedimentation rate and C-reactive protein, or CRP, again, simply indicating the presence of inflammation and autoimmunity. You may also observe a normochromic normocytic anemia in individuals with RA. In terms of clinical findings, if the synovial fluid is aspirated by arthrocentesis, it will appear opaque, which means you cannot see through it, and there will be increased white blood cells. A joint X-ray is also used in diagnosis, but will not show deformities or dysfunction until after at least 6 months of illness. Initially, there may be some minor swelling and osteoporosis around the articular joint, and later you will see joint space narrowing and erosion. Shown here are the diagnostic criteria for rheumatoid arthritis. This gives some information about who should be tested for RA, and specifically, this would be patients who have at least one joint with swelling, and that's not better explained by some other disease. If this is the case, many things can be examined to classify as RA, with a score of at least 6 needed for an RA classification. The first area to evaluate is joint involvement, whether many large or many small joints are involved. The serologic or immunologic findings, such as positive rheumatoid factor or positive ACPA test. The acute phase reactants, CRP and ESR, and the duration of symptoms. Again, a higher score is more definitive of RA, whereas a lower score might be another disease state or arthriticity. In terms of prognosis, about 75% of patients experience remission of their RA within 2 years. A poorer prognosis is indicated if the patient has had polyarthritis for at least 3 months, a lack of a therapeutic response, or early involvement of larger joints. Early treatment is important because it can prevent disability and joint destruction. Some of the complications that can result in the absence of treatment are things like muscle atrophy, carpal tunnel, as well as effects on the eyes or aorta due to vasculitis.